Welcome to Workshop 29 entitled Therapies Beyond Cftr. I'm Brad Kwan. I'm an adult respirologist from Vancouver, Canada, and I'm joined today by my co-chair, Dr. Deepika Polanini from the University of Kansas. Neither Deepika or myself have any conflicts of interest to disclose for this very brief introductory presentation. So, why are non-Cfdr therapies still required? Well, most of you are now very familiar with some of the initial data coming out following initiation of ivacaftor back in 2012. As you can see, based on this very nicely done study by Dr. Greg Sawicki, there is an upfront increase in FEV1 that occurs within the first 2 to 4 weeks. However, as you can see with these patients that were followed up to 3 years in the registry, there does continue to be a gradual decline in lung function, albeit at a slower rate compared to an F508 control group. Furthermore, as we look on the right of the slide, elexacaftor, tezacaftor, ivacaftor can have fairly dramatic effects in terms of mucociliary clearance, leading to reduced mucus plugging. However, even after treatment, there continues to be significant background bronchiectasis. For those of you that look after non-CF bronchiectasis, the disease can remain quite active with exacerbations of disease despite normal CFTR function. So what impact do highly effective CFTR modulator treatments have on airway inflammation and infection, which are hallmarks of CF lung disease? As you can see from this data from the GOAL study led by Dr. Steve Rowe, they were able to look at sputum inflammation and infection in a subset of their cohort, albeit a relatively small group. And as you can see on the top left of your screen, there appears to be fairly equivocal effects on sputum mediators of inflammation, including IL-8, neutrophil elastase, and IL-1 beta. On the top right of your slide, you'll see that approximately 50 to 55% of patients had evidence of Pseudomonas in their sputum prior to initiating ivacaftor. And at 6 and 12 months, the proportion of patients that remained positive was lower at 34 to 35%. This would suggest that CFTR modulator treatment may be having some beneficial effects in terms of airway infection. In another study performed out of the University of Washington by Dr. Katie Hissert, you can see that when patients treated with ivacaftor are followed out a bit longer, there may be beneficial effects in terms of airway inflammation. This was performed in also a fairly small subgroup of patients. And in contrast to the GOAL study, these sputum samples were obtained spontaneously as opposed to through induced sputum. However, with respect to Pseudomonas bacterial loads, you can see that while there may be initial decrease in the first 6 months of therapy, as patients are followed out longer, the bacterial load does tend to rebound. I guess some questions still remain regarding this data as to whether background non-CFTR modulator treatments were adhered to in the longer term, which may explain some of these results. So when we look at the CF therapeutic pipeline, there appears to be a number of anti-infectives in early phase clinical development. Unfortunately, when it comes to anti-inflammatory treatments and those targeting mucociliary clearance, the pipeline is much thinner. So with this background in mind, I'd like to introduce our roster of speakers. So in order for us to continue to investigate non-CFTR modulator therapies, we will need to understand better what our patient population's interest is in participating in clinical trials. And so Dr. Nicole Mayer-Hamblett will discuss some results from a survey they conducted in patients on highly effective CFTR modulator treatment. Then we'll move on to Dr. Harm Tiddens, and he will discuss the results from the SHIP-CT study evaluating hypertonic saline and its effect on structural lung disease in preschool children with CF. Our last two workshop talks focus on aberrant immune response and inflammation in CF. And so Dr. Matthew Long will discuss the immunomodulatory effects of MEK1/2 inhibitors on CF leukocytes. And we will end with a talk by Dr. Gail Stanley focused on Bacteriophage Therapy and its effects on CF lung inflammation. So I'd like to welcome Dr. Nicole Mayer-Hamblett to kick off this workshop. Thank you.
Good morning, good afternoon, and good evening to everyone. We're so happy that you're able to join us today. Just wanted to have a few quick words live before we launch into our first pre-recorded session. Yeah, we do really encourage you to try to put in your questions as we go through each of the talks. It'll be, a bit more of an enriching experience for everyone attending today. And I think we'll all learn from you through your questions. So I don't want to delay things any further, but we will launch into Dr. Nicole Mayer-Hamblett's talk.
Thank you so much for the opportunity today to share data on clinical trial interest after establishment of modulator therapy. I have no relevant disclosures. While the impact of CFTR modulators is significant, we are nowhere near done. The long-term effectiveness and safety of currently available modulators over the course of one's lifetime is unknown and necessitates continued investment in new CFTR modulators and additional disease-modifying therapies for this population. We also have the need for effective therapies to manage what may become residual disease among those who benefit from modulators, including chronic airway disease and infection. And there are people with CF who do not benefit from current modulators. Either they do not have access to these modulators, they are ineligible, or they may not tolerate these therapies. These development efforts necessitate continued engagement and interest in clinical trial participation among those on CFTR modulators. And as we think about identifying therapies that may have benefit among those who are modulators, these therapies are likely to have an even greater impact among those who don't have access to modulators. And so as we think about ways to advance and more quickly move our pipeline forward, particularly for those who critically need these therapies, having access to a larger development population and being able to develop therapies in both the modulator and non-modulator populations will be quite important as part of our strategy moving forward. So while clinical trial designs, including the modulator population, will be more complex, this planning is moot in the absence of continued interest in clinical trial participation. Broad interest is difficult to gauge, however. If we just ask the question, are you interested in participating in clinical trials? It would be hard to interpret the answer without the context of the class of therapy, duration of study, the use of placebo or not, and the requirements for withdrawal of standard of care therapy. Our study aimed to describe interest in clinical trial participation among those established and highly effective modulators, including both Cftr and elexacaftor, tezacaftor, isacaftor, or ETI, for select trial scenarios. We had an opportunity to survey our community through an ongoing study, CheckFC. This is a large epidemiologic study of sweat chloride and association with clinical outcomes. And the beauty of the study is it's a single study visit that occurs and needs to occur at least 3 months after starting a CFTR modulator. And patients have the opportunity to re-enroll if they switched modulators, as long as they have been on that new modulator for at least 3 months. So it's a very simple study design. It's a large study. We're actually recruiting over 5,000 patients by the time the study is over. And in terms of eligibility, any individual with CF 4 months of age or older that's on an FDA-approved modulator for at least 3 months is eligible. At enrollment into the study, we surveyed either the person with CF or a family member, depending on age, as to their willingness to enroll in future trials of different designs and duration. And we focused in on a couple of different trial scenarios, including those that were studies of a new Cftr modulator, looking at either having a placebo or active comparator control. And among those who are currently taking inhaled antimicrobials, we looked at clinical trial willingness of placebo-controlled studies of new inhaled antimicrobials. The survey was actually an amendment to the ongoing CHECK-SC study, and the amendment was approved in September of 2020. At this point in time, the CHECK study was targeting enrollment in ivacaftor pediatric cohorts and the ETI 12 and older cohort. So our survey data reflects data from these two modulator cohorts. We collected data on almost 900 subjects over this last year. So a very large cohort in a short amount of time who's been on a highly effective modulator for at least 3 months. We look at some aspects of our cohort. Their average age was almost 24 years old. The sweat chloride change as a whole cohort was about 53 millimoles per liter. And this, the genotype, of course, reflected those reflecting the approvals of ivacaftor and ETI. The majority of our cohort is actually on ETI in this survey population, 97%. And the average FEV post-modulator at the time of enrollment in CHECK was fairly high at almost 86%, with the majority of participants being in that 70% or higher category. And as I said, we had a mixture of family members or persons with CF responding. For the majority, those family members with children under 12 years of age actually represented those who are enrolled in the pediatric ivacaftor cohort. Overall, however, the majority of our respondents were the persons with CF responding on behalf of themselves, 81% of the cohort. If we look at various modulator trial scenarios that were posed, and in this setting, we're focusing on trial scenarios of a new modulator hypothesized to be as effective as ETI. So under that context, we asked the willingness to participate in either placebo or active comparator trials. And as you see here, of course, willingness to participate in active comparator trials was higher than placebo-controlled trials. But, in general, there was actually very high willingness to participate, particularly for the shorter durations. For active comparator trials, it started out about 82% for 2-week trials and then dipped down to 65% for trials of 6 months. And for placebo-controlled trials, it was still relatively high for those short duration trials, 76%, and then dropped down to 53%. Now, it is worth noting that although we asked for willingness to participate in some of these longer-term placebo-controlled trials, these are very unlikely designs in consideration of potential withdrawal syndrome and what we are seeing in various cases presented and in the literature. And out of cause for safety, we would not typically be pursuing these longer-term designs. We also looked at the effective design modifications on willingness to participate, including adding on a 2-week washout at the start, which was not very popular, extending the duration in any manner to these studies. However, there was quite a willingness to participate for new modulators that may be better than ETI. And then, somewhat moderate, increase in interest of adding on a 6-month open label follow-on to any of these designs. We also looked at the association between key participant factors and the willingness to participate in a 1-month placebo-controlled trial. That's about the longest we could potentially ever explore in this type of setting. We saw some trends here that the younger you were, that the less likely you were your willingness dropped in trial participation. The more clinical trial experience you had, the more willing you were to participate, be willing to participate, including unknown study participation. Unknown prior trial experience was also associated with slightly higher willingness. And interestingly, modulator responsiveness was showing some association as well. The higher your sweat chloride was at your visit post-modulator, the more likely you were to have interest in clinical trial participation. And the lower, the greater the drop in sweat chloride, the less likely there was an association with clinical trial interest. Now, just keep in mind, however, that these relative comparisons are, in contrast to the absolute, willingness that we saw that was about, 70% in this population. And among the subset who are on inhaled antibiotics, which is about just over 300 patients, this was a slightly older cohort, and but their FEV was lower, including mostly those who were above 40% in this cohort. And the majority of this cohort were on ETI. We found similar trends here in terms of interest in participating in short-term trials up to 1 month, and then a great drop-off after that. And that's not too surprising given the intermittent nature of these antimicrobial trials and that window of time with up to 1 month that you could really take advantage of a placebo-controlled trial. Adding on a 6-month open label period did increase interest moderately in this cohort. We also looked at the association between key participant factors and willingness to participate in a 1-month placebo-controlled inhaled antibiotic trial. We did also find that age, the younger you were, there's less of an association, less willingness to participate. And then interestingly, actually, this was kind of a good internal control for the cohort. If you were on intermittent therapy, you were more interested in clinical trial participation, which makes complete sense. We didn't find a strong relationship here with modulator responsiveness and trial willingness in this setting. So as we step back and look at this data in totality, I think we need to break down some, natural inclinations that the acute perception or need for therapies is directly correlated with clinical trial interest. Here, we have a modulator cohort that may not necessarily, need some of these therapies, but demonstrated overall, fairly high interest in future trial participation, particularly for short-term clinical trials. So about 2/3 of this large study population on highly effective modulators indicated a willingness to enroll in future clinical trials of CFTR modulators or inhaled microbial trials. The willingness to participate in placebo-controlled trials requiring an absence of standard of care is evident, but is highly dependent on study duration, where that willingness was highest through 1 month duration. Other design elements affected interest, including the choice of comparator, the initial washout, or 6-month open label access. And interestingly, there were more characteristics, including those related to modulator response, were associated with willingness to participate in a 1-month placebo-controlled modulator trial as compared to a similar duration antimicrobial trial. There are several limitations to this study. I mean, one, this is interim data, so associations may change as we get more data in on a broader cohort. The second is that the survey was comprised of clinical study participants in Czech. So it's conditional on a cohort that was already enrolled in a clinical trial. It may represent a highly engaged, although large cohort from TDN setters. These patients enrolled during COVID-19, so they may select slightly biased population. That said, Cftr as a single study visit was successful as a study enrolling individuals new to research. It was designed as a platform to engage a broader community than we traditionally do for our clinical trials. The other caveat is that interest in CFTR modulator trials was asked without the context of informed consent, outlining the potential risks of withdrawal or switching modulators. We are aware of the reports of withdrawal syndrome that may impact the risk-benefit of these trials as they could be described in a consent form moving forward. And I think it's important to note that the willingness may decrease for both placebo and active comparator studies. The active comparator arm has to be hypothesized to be as effective as ETI to really mitigate those potential risks. So in conclusion, there's a large portion of the CF community on established highly effective modulators, which continues to exhibit engagement in future CF clinical trials. This engagement is a critical foundation to move new therapies through the pipeline. And we must now progress with new roadmaps for CF trial design, which, although complex, are inclusive of both the modulator and non-modulator populations. So thank you on behalf of the CHEK-SC subjects, study team, and investigators, and to the CF Foundation for funding this study.
Thanks, Nicole, for that very interesting and thought-provoking talk. I'm just going to start off the questions as they keep rolling in. I guess the first question I have is, were these results surprising to you? I know you did mention that this is a fairly selective group that completed the survey. And do you think that the results differ from prior surveys that were done pre-highly effective CFTR modulators?
Yeah, so I mean, yes and no. I mean, I think they were surprising given the fact that, ETI is such an effective modulator and, life-changing, for many individuals. But on the same hand, this continues to show the engagement of our community. These results actually are quite similar to a survey that we did after Cftr was introduced about 4 or 5 years ago. We surveyed that population and saw very similar results in terms of clinical trial interest. Really also confirming that duration has a really big impact on many of these clinical trial design scenarios and interest.
Great, thanks. Maybe a related question that's come up from Theta Ong. Just the question relates to withdrawal syndrome or potential thereof. Was that described in the scenarios? And, obviously would that impact study duration?
Yes, I think I noted that as one of the major limitations. And in fact, some more recent reports came out after we designed the survey. And so I don't think we thought about that, how to incorporate that when we were designing the survey. But in hindsight, that is likely going to be a factor. And in fact, as we ask those scenarios, it may be that, if we were able to do a placebo-controlled trial or something, it may only need to be a week or so. But on the other hand, we're also really thinking that we're going to need other trial designs for this scenario. Perhaps looking at external control groups. I gave a talk yesterday mentioning that we're pursuing other innovative trial designs such as synthetic control arms that would not, require placebo-controlled trials to act as that comparator group. I will say, though, it also points to the need to, for new modulators coming into the pipeline, there really needs to be strong preclinical data to show that, we're within the range of their current modulator therapy. Even for an active comparator trial, we really are going to need, substantial effectiveness to roll somebody on off of their current modulator therapy onto a new modulator. If we have concerns about potential withdrawal, that level of activity is going to have to be, within the same range.
Great, thanks. Another question related to advanced CF lung disease and lung transplant recipients in trial participation. Will future studies be able to extend these surveys into these vulnerable populations as a subgroup?
Yes, I mean, I think that the beauty, with CHEK is that we are, collecting data on a very broad population. We haven't looked at that those with advanced lung disease. We probably have some in our cohort to look at their trial interest. I think that question too about doing trials in this advanced lung disease population, I think absolutely. I think the issue is really safety. I don't know that we would start a new therapy necessarily in that population because we want to establish safety first, in a less vulnerable population. But once that's established, I think, where there's a role to bring that down, below 40%, where there could be effectiveness. I think that's where we have to consider, in order to make sure that those patients can benefit from these therapies.
Yeah, and I guess we have to think historically, like disease has changed now, right? So that group where we may have been a bit more concerned about, various them having frequent exacerbations and stuff, that may be less of a concern.
And what's interesting now is our population is changing. When we think about, a lot of trial designs have a ceiling for their eligibility of 90%. They enroll everybody up to 90%, but now our population on average is moving above 90%. So we're going to have to, learn whether or not those who are above 90% can still benefit from these other additive therapies. My gut is that, some of them, will benefit. And so we need to relook at our traditional cutoff criteria that we've been using for trials, and in parallel with just how we're understanding this new, disease and how we better enrich our trials now post modulators.
Great, thanks. Follow-up question by JP Clancy related to, are you going to be serving these patients in the longer term because their initial interest may differ compared to maybe, 2 or 3 years after introduction of a highly effective modulator?
Yeah, that's a very good, that's another limitation, is that we, survey these patients, and in particular, since we caught them over this last year, they may have only been on the therapy for literally like 3 months. And so as they begin to adjust to this new normal, their thoughts may change in terms of clinical trial interest. So that may wane. I will say, when we did the ivacaftor survey, those patients had been on ivacaftor for a longer duration, and we were still seeing high percentage interest. I'm not sure if that would go the same way, across our broader patient population. But I think that's a really good question. CHEK, unfortunately, is a one visit where we would have the chance to do it, is if we, if there's another modulator and these patients switch down the road, we could consider surveying them again, because they would re-enter into our trial.
Thanks. I think we have time for a few more questions. Dr. Jennifer Taylor-Calzar asks, is there a difference in response by age group?
Yes, in terms of, very broadly, if a family member was filling it out, which is our pediatric patient population, there was generally less interest in clinical trial participation. We still haven't looked through, because this was sort of an interim snapshot, we haven't done a careful assessment of all of our demographics in association with clinical trial interest. And so that's definitely on our list to dive deeper into, including race, ethnicity, and other predictors that we are able to obtain from the CF registry.
Great. Last question here is, did you gauge willingness to participate in trials with more invasive procedures such as BAL to get sputum samples in the post-modular era?
No, we didn't. Hindsight, and it's funny because we designed the survey quite some time ago. So hindsight's 2020. If we did it now, we probably would have added a lot more questions. Especially as sputum is difficult to get. That would be interesting to know.
Yeah, I think a lot of groups are grappling with that issue in terms of if you're using sputum bacterial loads, for example, as an endpoint in your trial.
Right.
So with that, I think we will end this Q&A session and introduce our next speaker, Dr. Harm Tiddens.
Hello, good morning. I'm Harm Tiddens. I'm a pediatric pulmonologist at the Erasmus Medical Center in Rotterdam, the Netherlands. Today, I'm going to present to you the effect of inhaled hypertonic saline on structural lung disease in preschool children with cystic fibrosis, the SHIP-CT study. First, my conflict of interest. For this presentation is relevant that the Erasmus Medical Center and Teleton Kids Institute are license holders of Pragma CF, and that I have a joint public-private innovation grant with an image analysis company, Terona, for the development of image analysis software, and that I also consult for this company. Some background: cystic fibrosis lung disease is characterized by early inflammation, infection, and structural lung abnormalities, which can be observed on chest CT. It is known that inhalation of 7% hypertonic saline can increase liquid hydration of airway surfaces and can improve mucociliary clearance. In the SHIP study, it was shown that 48 weeks of treatment with inhaled hypertonic saline resulted in improvement of LCI relative to the control group. However, in that study, the effect of hypertonic saline inhalation on lung structure was not investigated. We therefore have had the objective for the SHIP-CT study to compare the effect of inhaled hypertonic saline on lung structure as measured from standardized chest CT at end of study relative to isotonic saline treatments. Study design: this was a multi-center randomized double-blind controlled parallel group trial. CF patients aged 3 to 6 years were included in Europe, Australia, and North America. Patients were randomized 1-to-1 to hypertonic saline, the treatment group, versus isotonic saline, the control group. Inhaled twice daily, the drug, for 48 weeks. And there were 6 study visits included in the study. And here, the study overview is shown. The screening visits, patients had a test dose with inhaled hypertonic saline. In addition, they received training in the breath hold maneuvers, and that was, of course, to optimize the execution of the chest CT and to reduce anxiety of the patients. This training was repeated on the enrollment day, and when the CT was successful, the patient was enrolled in the study. Training of the breath hold maneuvers were repeated at 12, 24, 36, and 48 weeks. And at 48 weeks, the end of study CT was executed. LCI was measured at screening, enrollment, 24 weeks, and 48 weeks. CTs were analyzed using the Perth Rotterdam annotated grid morphometric analysis for CF. That's a mouthful. It's the Pragma CF scoring method. This is basically a annotation system based on morphometric principles. You take a stratified random sample of all available slices of the chest CT, and these slices are equally spaced. Next, you put a grid over each slice, and the observer will annotate the content of each grid cell and will determine whether the content looks healthy, whether it's bronchiectasis, mucus plugging, airwall thickening, or atelectasis. This is for the inspiratory scan. On the expiratory scan, the only two items that are annotated are whether it's healthy or whether there is trapped air available. Next, the software automatically computes the volume fraction of each of these components. So these subscores are expressed as percentage of total lung volume. Percent disease is the primary outcome measure of the study, and that is a sum score which combines the subscores bronchiectasis, mucus plugging, and airwall thickening. The advantage of this is that this outcome is independent of the hierarchical order by which the grid cells are scored. The statistics, primary outcome is the difference in PAGMA-CF percent disease at 48 weeks between groups. Missing values in the percent disease at 48 weeks are counted for using multiple imputation. Using linear regression, we adjusted for baseline differences in percent disease between groups. Secondary outcomes were difference in PAGMA-CF percent bronchiectasis and percent trapped air at 48 weeks between treatment groups. And again, this was corrected for baseline differences. For LCI, we looked at the change from baseline to 48 weeks between treatment groups. Intra and inter-observer reliability was assessed using two-way mixed effect model. So this slide shows you the study profile. There were 134 patients screened, 116 patients randomized, 56 were randomized to hypertonic saline, of which 49 completed the study, 60 were randomized to isotonic saline, of which 55 completed the study. This table shows you the baseline characteristics for hypertonic saline, the left column, and isotonic saline, the right column. Patient groups were well matched for age, sex, Cftr genotype, race, weight, height, and the LCI, and for all subscores except for percent trapped air that was higher in the isotonic saline group relative to the hypertonic saline group. Image quality of the CTs was of great importance for sensitive image analysis, and this was assessed using semi-quantitative scoring system. And this showed that at 48 weeks, the inspiratory scans were all within the good and moderate category, and for the expiratory scan, 97% were within good and moderate category. Also, what you can observe here is that there is clearly a treatment of a training effect going from baseline to 48 weeks. Important to notice is that all CTs were of sufficient quality to be annotated using the PAGMA-CF scoring system. Intra and inter-observer reliability, as assessed using ICCs. For the intra-observer reliability, all subscores were in the excellent range. And for the inter-class correlation coefficients, all the primary outcome and secondary outcomes were all in excellent range. This shows you the study results for percent disease using a rain cloud plot. On the left, a split violin plot that gives you an idea of the distribution of the data. Then there is the box plot with showing the median and the interquartile ranges, and the spaghetti plot showing the trajectory for the individual patients. If you look at the distribution of percent disease, this distribution is actually quite similar to what we have observed in previous study that included preschool children. So there is a substantial proportion of the subjects show relatively mild abnormalities. However, there are also a high number of patients that have moderate to severe changes. And especially in isotonic saline group, you have the idea that it is progressive over the 48 weeks study duration. To give you a better feeling for what these numbers mean, we show you here 3 examples. So the patient panel on the patient on the left has a percent disease score of 0.63, and at the end of the study 0.67, so quite stable disease. And this number is actually slightly below the median value for the group, and it shows primarily diffuse airway wall thickening. In the middle panel, you see a patient with a score at the baseline of 2.05, and you can clearly see the thickened airway wall, and you see bronchiectasis airways. This over the 48 weeks increased to 3.63, so clearly an increase in structural lung abnormalities in this patient. And on the right panel, you see actually the most severe patient of the 116 study participants. This patient had at the start of the study a 20% of lung volume with abnormal airway features, and it even progressed during the 48 weeks to 27.5%. So the primary outcome, we observed a significant difference, p-value of 0.02 in PAGMA-CF percent disease at 48 weeks between groups. So the score at the end was 0.93 for the hypertonic saline group and 1.6 for the isotonic saline group. The mean difference between the groups was 0.67. And again, to give you an idea about the meaning of this number, here we show the trajectory of one of the patients who had at the start a percent disease which was close near the median of the whole group, 0.87. At 48 weeks, this patient increased by almost 0.6, and which meant that at baseline there were 70 airways that could be evaluated, of which 16 were abnormal, 20%. At 48 weeks, 103 airways were visible, of which 33 were abnormal, meaning there was a 10% increase in the percentage of abnormal airways, so a substantial change in structural abnormalities. The secondary outcomes show exactly the same pattern. On the left, in the left figure on the left, we show you the percent bronchiectasis, and there was a difference between the hypertonic saline group and isotonic saline group that was had a p-value of 0.02. And on the right, you see a large difference in the percentage of trapped air, which was 0.92 for the hypertonic saline group and 2.88 for the isotonic saline group, with a p-value of 0.005. This shows you the LCI results. And again, to remind you, here we looked at longitudinal changes, and it showed an increase for the isotonic saline group and a decrease for the hypertonic saline group. This didn't reach significance, p-value of 0.06. We did a post hoc analysis using the same statistical method that we used for the chest CT, which meant that we looked at the difference at 48 weeks and we corrected the difference for baseline differences. And that difference was significant at the p-value of 0.04. Hypertonic saline treatment is considered safe in general, and also the SHIP-CT study supported that. There were only 4 major life-threatening events, of which 3 were mislabeled actually, like nasal congestion. And there was one of these life-threatening events was a admission for respiratory tract exacerbation, and that was in the isotonic saline group. So in conclusion, maintenance treatment with hypertonic saline in preschool children with CF for 48 weeks improves trajectories of structural lung disease on chest CT relative to isotonic saline. CT and LCI results of SHIP CT are in line with the SHIP study, showing a positive effect of inhaled hypertonic saline. So based on the SHIP CT and the SHIP study, we can conclude that hypertonic saline is an effective, safe, and cheap treatment option for preschool children with CF. And chest CT is a feasible outcome modality in preschool children with CF. And finally, the primary outcome, Pragma CF % disease, is a sensitive outcome measure in preschool children. Finally, I want to acknowledge all that participated in this challenging study, which was executed in the EU, US, and Australia. And I think everybody did a fantastic job to make this study work and get the CTs done and the LCI in this very difficult age group. And of course, we thank the children and caregivers for their participation. And finally, I want to thank the CF Foundation for who made it financially possible to do the study and who also managed parts of the study. Thank you very much, and I look forward to your questions.
Thank you, Harm, for an excellent talk. We're going to move into the questions. We have a bunch of them to catch up with here. First question is, what LCI device was used across the study sites, and what procedure did you use?
I couldn't tell you in detail which devices. I only know that all sites were certified by Toronto and by London. So everybody used the same standardized methods.
Okay, thanks. A question, are there any imaging phenotypes of response to hypertonic saline, such as distribution of disease, whether it be upper or lower lobe, peripheral versus central bronchiectasis, degree of mucus plugging?
Yeah, so the Pragma CF system doesn't really allow to say something about distribution. However, if you look at the histogram of looking at how the disease severities are distributed over the patient, there's actually a pattern which you see in many cohort studies for which we used Pragma CF. So the patients with very mild disease, but also about 1/3 of patients have quite severe disease, stressing the need actually for early intervention, because as was shown by your CTs, if once there are severe bronchiectasis, you might clear out those airways, but they remain vulnerable. So patients, even if you cure CF, they still will be bronchiectasis patients. We will, however, we plan to do a more in-depth analysis using this airway artery method that I mentioned with my conflict of interest, which allows you actually to look to investigate per lobe the actual distribution between the airway artery ratios throughout the bronchial tree within the lobe. And that will give us some more ideas about the distribution of severities across lobes and also in terms of the response, more detailed information.
Okay, thanks. Felix has weighed in. All sites use the Echomedics device,
okay,
and it was analyzed with updated software version. Okay, there's a question from Greg Sawicki. Were there observed differences in symptoms, caregiver quality of life, or treatment burden?
Well, for the treatment burden, of course, that's equal. In terms of side effects that were reported, distribution was equal. There was more cough in the hypertonic saline group. But if you look at adherence to the treatment, used ampoule count for what it is worth, that was actually high. It was in the order of 0.9 for both groups, quite similar. So we didn't have any concerns on safety.
Great, thanks. Question from Theta Ong. Are pragma methods automated, able to use artificial intelligence methods, and maybe less human decision-making?
Yeah, so first of all, the scoring was done by PhD student Yuxin Chen, and she had a ICC which comes close to, I think, what the computer can do. It was all in the excellent range. But of course, it's time consuming and not accessible for all centers. So both Tirona as Resonance Health are automating it using AI. And actually both have announced that they have automated it. And we expect that software will be certified within the next year somewhere.
Great news. Question from Jennifer Taylor Calzar. Can you discuss the risks of sedation for CT, especially in younger kids? And can we only use CT in clinical trials, or is it going to be feasible to follow kids over time in an era when the median predicted survival is, middle age in many countries?
Yeah, of course, if you talk about CT, radiation is always an issue. And half of the centers in Europe are using it routinely. Actually part of the CTs were actually part of the routine follow-up. So there was, for this study, one extra CT was included. The CTs were, except for the CTs in Australia, were all done with non-sedated children. So there are no risk related to that. And in Australia, it was done in, I think, 7 children under general anesthesia, because that is their routine as part of the Arrest CF protocol. So as Nicole Hamblet mentioned, spirometry is not sensitive enough to monitor progression of disease. And I think, therefore, CT will remain, especially in studies, will be important to inform us whether what happens to progression of disease. Localized abnormalities can occupy very little volume, and therefore you will not see it in spirometry, while on the CT you can measure it quite easily. So I suspect that imaging, and of course MRI is in development, but standardization is quite challenging. So I think the use of chest CT, and also with the now recently being introduced new techniques like photon counting CT, which will reduce radiation substantially further, I think CT will continue to have a place in the monitoring of patients. But we have to stratify the follow-up protocols according to risk factors, and those protocols we have to develop.
Thanks. Edith Samanik has a question related to the clinical trials. Is what would you consider as a MCID for the pragma measures?
Yeah, so we struggled with that at the time when we designed the study. We said that a difference of 1.44, which represented a 1/3 reduction percent disease, we would consider that significantly substantial, clinical meaningful. But the percent disease at the start of study was lower due to systematic differences in the scoring between the group that we used to calculate the sample size. And we still obtained a 1/3 reduction in the study. And further, the difference between the treatment groups actually represent the 1-year progression that we observed in multiple cohorts. So I think to reduce progression the equivalent 1-year progression in the active treated group, I consider that clinical meaningful. It's a 1-year reduction, basically.
Okay, thanks. She also asked whether the baseline differences in the extent of gas trapping may have influenced the results.
Yeah, we accounted for that using our statistical method. And we adjusted for baseline differences, also for percent trapped air, and we corrected for age. That was not shown in this presentation, but that was actually in comment by the reviewers on the paper that we submitted. So we repeated our analysis, also adjusting for age, and it didn't change the results. So I think the interesting thing about the gas trapping, it's called gas trapping, but it's actually what we look at is low attenuation regions, and it reflects actually probably a mix of really trapped gas, but also of hyperperfusion. I think we really have to understand better what is the let's say the histological equivalent of this abnormalities, and especially we have to learn about reversibility, also in relation to the modulator therapy.
Okay, I think we have time for one last question from Dave Nichols. Do you believe there are any noise in the imaging analysis that could be improved by determining what imaging changes are associated with clinical improvements in those participants and focusing or weighing more on those aspects of the scoring?
Yeah, I think by the way, I liked his presentation that I saw this morning in my time, but what we actually observe, what's an important change is in airwall thickness, and that represents mucus. Actually, what we interpreted airwall thickness is actually the mucus that's glued to the airway wall. So I think the improvements that we see is related to really reduction in mucus impaction in the airways, and I think that is captured actually quite well. To our surprise, we also observed a substantial difference between both groups in bronchiectasis, and that actually we did not expect that we'd find it. And again, we will analyze it with more precise AI-based methods, looking exactly what happens to the airway dimensions as a, let's say, an objective measurement for bronchiectasis.
Okay, yeah, sorry, I just want to add one last question related to that is, have you looked at the relationship between different pragma domains with LCI and those changes?
Yeah, so we will do more in-depth analysis of the relation between the structural changes and the multiple breath washout outcomes. If we look at percent disease and trapped air and the correlation with the changes in LCI, it actually doesn't correlate. So basically, it gives you different information, which is not surprisingly, because on a CT scan, you can, in a child, probably when there are diseased airways, observe airways up to the 12th generation, but that still leaves like 13 generations which you can't see. So LCI might actually pick up changes which are more peripheral than what we can observe on the CT scan, and therefore I think again this low attenuation regions are of interest, and we have to do a more in-depth analysis for that.
Okay, thanks so much, Harm. And thanks for the audience for all the great questions. We'll move on to our next speaker, Dr. Matthew Long.
Thank you.
Hi, my name is Matt Long, and I'm happy to present our work in this workshop. And the title of my presentation is Evaluating the Immunomodulatory Effects of MEK1/2 Inhibitors on CF Leukocytes. So I have no relationships to disclose related to this presentation. So the objective of my lab is to really, the ultimate goal or aims are to develop CF translational therapies. And today I'm going to talk to you about the anti-inflammatory and antimicrobial therapeutic potential of MEK1/2 inhibitor compounds. And this line of work really pulls in findings or observations from people and cells from people with CF, and then CF animal models and cells, but it leverages advances made in cancer drug discovery field, as well as more generalized microbiology infectious disease research that has taken place. So as you may be aware that in human CF, the lung has an abundant amount of inflammatory leukocytes. Shown here is a human CF lung explant standing for CD68 positive macrophages and MPO positive neutrophils, just showing the high level of inflammation present in these lungs. And we're interested in trying to decrease the recruitment or toxic effects of these cell types in the pulmonary airway of people with CF. And so previously, there have been some anti-inflammatory therapies developed for CF. Of course, azithromycin has some immunomodulatory effects, corticosteroids, high-dose ibuprofen, but there is a cautionary tale of LTB4 receptor antagonists, which did reduce neutrophil-mediated inflammation, but however, they did it so well that it seemed to impair host defense mechanisms. And so this is kind of a theme that we're investigating in our studies. And so our lab is interested in the functional responses of macrophages and neutrophils. And shown here is some data using mirroring bone marrow-derived macrophages from wild type or Cftr knockout mice that have been either resting or stimulated with LPS, and looking at pro-inflammatory gene expression such as TNF-alpha and IL-1 beta. And what I think you can appreciate is that the Cftr knockout or deficient cells have increased pro-inflammatory responses. So similar findings have been reported on by other groups, suggesting that Cftr dysfunction increases macrophage pro-inflammatory responses. On the other hand, some other groups have published that CF macrophages have defects in their anti-inflammatory programming. And so the picture kind of results in a skewed pro-inflammatory or M1 polarization phenotype for CF macrophages, with a decreased or inhibited or defective anti-inflammatory or M2 polarization programming. So the central hypothesis that we've been studying is that inhibition of these pro-inflammatory phenotypes, along with concurrent promotion of M2 polarization and the ability of these cells to phagocytose or ingest apoptotic cells, such as apoptotic neutrophils, would reduce detrimental lung inflammation in CF. So to try to do this therapeutically, we need to understand what signaling pathways regulate macrophage polarization and their functional responses, and then can these be targeted therapeutically? So our work is focused on both pro-inflammatory M1 polarization phenotypes of macrophages, as well as M2 polarization and phagocytosis abilities. And the approach we took to study this was to examine available therapeutic compounds, ideally ones that were FDA approved or in clinical trials. And we looked for targets that overlapped with known or reported dysfunctional responses in CF cells. And so what I'm going to talk to you today is the role of the MEK1, MEK2 pathway. So these are protein kinases that sit in signaling cascades, and about a third of cancers have aberrant MAP kinase signaling through this pathway. And this is typically overactivation. So upstream regulators such as RAS and RAF signal through and phosphorylate and activate MEK1 and MEK2, which can phosphorylate and activate downstream targets such as ERK1 and ERK2. And so because this is very prominent in human cancers, inhibitor compounds targeting MEK1 and MEK2 for inhibition have been developed for several decades now. And so in the mid-90s was this first compound that kind of came out. But since then, many different pharma companies have gotten in on this, this pathway of MEK1 and MEK2 as a target for inhibition. And these are just, this is a non-inclusive list, but showing different MEK inhibitor compounds that have been developed. Those in yellow denote ones that do have some FDA approval already for BRAF mutated melanomas. So we're interested in this pathway for a couple of reasons. One of them is that overactivation of the MEK1/2, ERK1/2 pathway has been shown to occur in different CF cells, including epithelial cells, due to bacterial stimuli, but also CF or cigarette smoke exposure, and that this pathway is important for regulating the inflammatory response and also regulating CFTR. And there's also work been done in macrophages suggesting that overactivation of this pathway following LPS stimulation can promote detrimental pro-inflammatory responses. So we acquired human CF lung explants and stained them either here for IgG control or phosphorylation of ERK1/2, which we use as a marker of activation downstream of MEK1 and MEK2. And what we see in the CF airway, there's a lot of inflammatory cells that have very high activity of ERK1 and ERK2, including mononuclear cells in the airways that are very likely monocytes and monocyte-derived macrophages or alveolar macrophages. So our studies have focused on understanding how the MEK1/2 pathway can regulate macrophage programming. And today I'm just going to tell you a little bit about how this pathway and these inhibitors targeting it can regulate the M1 polarization or pro-inflammatory response of CF macrophages. And so following stimulation such as TLR4 by a lipopolysaccharide or bacteria, MEK1 and MEK2 are phosphorylated and activated, which then phosphorylate and activate ERK1 and ERK2 that can result in pro-inflammatory gene expression depicted here as IL-1 beta. And this is using mirroring bone marrow-derived macrophages from Cftr knockout mouse that are either unstimulated or stimulated with LPS in the presence of either vehicle or 3 different MEK inhibitors here. We see that LPS stimulation compared to the control induces a robust activation of this pathway. But the inhibitors of MEK1 and MEK2 significantly reduce this. And when we look at pro-IL-1 beta as a measurement of the inflammatory response, we see that MEK inhibitors or inhibition of this pathway significantly reduces the pro-IL-1 beta, which is quantitated here. And we've reproduced this using monocyte-derived macrophages from people with CF and see very similar results. So as I briefly mentioned earlier, so we think this is a good, these inhibitors are very good at reducing the pro-inflammatory responses of these macrophages of leukocytes. But as I alluded to earlier, one of the concerns is that you may impair host defense mechanisms by providing such an anti-inflammatory treatment. And so we took an approach to try to quantify whether or not inhibition of the MEK1/2 pathway modulates the critical innate host defense mechanisms of macrophages and neutrophils. And so the data I'm going to show you is using pH rhodo labeled bioparticles of either Staphylococcus aureus or E. coli. And so at neutral pHs, when these are outside of the cell, these bioparticles do not have a fluorescent expression, but when they're internalized and this phagosome compartment that they're internalized into matures and the inside is acidified, the pH rhodo label and the ones that we use have a red fluorescent, which you're able to detect by flow cytometry. So we can feed these particles to leukocytes in the presence or absence of MEK inhibitors and get a measurement of both phagocytosis and phagosome maturation. And so shown here is human monocyte-derived macrophages acquired from people with CF that have been fed opsonized Staph aureus, pH rhodo red bioparticles. And quantitated here is the percent of macrophages or MDMs that have a pH rhodo positive signal in them, and compared to vehicle controls, treated controls, application of these 3 different MEK inhibitors does not reduce the ability of these macrophages to ingest these particles. Compared, we have cytoclase in treated cells that as a control for inhibiting ingestion of these. And when we looked at the positive cells from these populations, we looked at the median fluorescence intensity of the pH rhodo, and we don't see any changes. We don't see any inhibition in the fluorescence intensity. We did see a significant increase between vehicle and 1 MEK inhibitor, suggesting that these particles perhaps are more fluorescent due to a higher increased acidification of the compartment. However, we don't know yet if this is biologically relevant. But we don't see defects by adding these inhibitors in acidification. So that was with Staph aureus. This is showing the same assay using opsonized E. coli bioparticles. So these again are human monocyte-derived macrophages, showing the percent pH rhodo positive. We don't see any statistically significant differences when we add MEK inhibitors compared to vehicle-treated controls in these. So we conclude that the presence of these inhibitors or inhibition of this pathway does not impair this critical innate defense function of macrophages. So we're doing similar things with neutrophils from people with CF, and in our preliminary data with both Staph aureus or E. coli bioparticles, it doesn't appear that application of these MEK inhibitor compounds is reducing the ability of neutrophils to phagocytose these particles. So in summary, the MEK1/2 pathway activation is present in human CF inflammatory cells in the lung. These inhibitors can reduce CF macrophage pro-inflammatory responses, but importantly, they do not appear to inhibit CF leukocyte phagocytosis or phagosome acidification. So I just want to put this briefly in the broader context in that MEK inhibitors have really global relevance. And this is some of the studies I think are going to be informative for our potential translation of these to CF, people with CF. And so it's been known for actually since 2001 that during viral infection of epithelial cells, such as influenza A virus, application of MEK1/2 inhibitors is able to block viral replication by inhibiting export of IV, in this example, and P from the nucleus. And so why this is relevant now is that this seems to be a common theme with many viruses, including SARS-CoV-2. And there is an ongoing phase 2 trial in hospitalized non-ICU patients for application of a MEK1/2 inhibitor compound. So I think this is important in terms of evaluating whether or not these inhibitors, which we know and others have shown in a variety of contexts now, can reduce detrimental pro-inflammatory responses, whether or not they may increase susceptibility to infections by host impairment. So our studies are also excited about these compounds because they seem to also retain the ability to have actually direct antibacterial effects. And so this is published literature showing that one of these MEK inhibitor compounds can have antibacterial effects. And we've repeated some of this data. So this is looking at broth culture, subculture growth of Staphylococcus aureus, and that we can reduce this growth with MEK inhibitor. So basically all bacterial species have eukaryotic-like serine-threonine protein kinases, and we and others hypothesize that some of these MEK inhibitor compounds may cross-react directly with bacterial proteins in Staph aureus, for example. So our future directions are to determine if addition of these inhibitor compounds impair CF leukocyte killing of Staph aureus or Pseudomonas, and then look at these in preclinical animal models of using CF mice to see if they can reduce pro-inflammatory responses and help clear infections. So I'd just like to acknowledge those in my lab at Ohio State University and the previous team I worked with at the University of Washington. Thank you.
Thank you, Matthew, for that excellent talk. You're definitely delving into a very challenging area in terms of anti-inflammatories, and it's always an issue as to how to find the right dose for the individual patient without, damaging their host response, which I think you showed some good data, at least reassuring data at this point. I'm going to start off with the first question by JP Clancy. He asked, he may have missed this, but is ERK1/2 signaling in macrophages and PMNs limited to phagocytosis?
So that's a great question and an area we're interested in, but generally speaking, I would say no. MEK and ERK definitely have roles in programming, transcriptional responses, and that's by intranuclear effects. They are obviously involved in many different, receptor signaling cascades, as well as just some different membrane trafficking events in the cell. But a lot of those are not exactly well described, depending on your context, and those can change, depending on your phagocytic target or other TLRs that may or may not be engaged. So that is an area that we're interested in investigating, and we have other tools to kind of try to dissect differential roles of MEK1 versus MEK2 in regulating those responses.
Thanks. In terms of next steps in clinical translation, I think you did mention that you'll be looking at this in animal models. Is there specific model systems you're going to be evaluating?
Yeah, I think despite, limitations of the CF mouse models, those are kind of the next step that we're going to pursue, which is kind of, so I mentioned the LTB4 receptor antagonists, and those sort of chronic infection studies were eventually done using CF mouse models, and they did kind of recapitulate the phenotype that was, seen in the halted trial in people with CF. So I think that, doing chronic infection, or I should say more chronic infection models using agar bead installations of either staph or Pseudomonas or potentially co-cultures are going to be important in those mouse models. Whether or not there's a role for utilizing some of the other CF mouse models, such as the rat or ferret, I don't know. We haven't really thought about pursuing that as the next step yet, but that could be a long-term or something after the mouse, I would think. But yeah, I mean, our hypothesis, at least for staph, is that these inhibitors might actually increase bacterial killing in these models. So I think we'll be able to see that using the mouse model.
Great. Obviously, there's some emerging data on the impact of Cftr modulators on macrophage function. The question relates to the intersection between, regulating this pathway versus, how Cftr modulators are.
Yeah, that's a great point. And the great thing that these modulators are doing for people with CF is fantastic. I think as this whole, as the opening suggested, there still is a role for these inhibitors. We haven't yet looked at how these perform sort of when the modulator compounds are also present, which would be relevant in vitro studies to do. The human monocyte-derived macrophages we use from people with CF, of course, a lot of our donors are on modulators, but we culture those ex vivo for 7 days to differentiate. And we don't have the modulators in the cultures when we do those. So we don't really know. We haven't really looked at yet how these the combination of these with the modulators may alter phenotypes, but that would be something worthwhile to look at, I think, because it's definitely relevant to the clinical setting.
Sure. The next question relates to the target population for this therapy, like what age it would be used for eradication.
Yeah, that's a great question. I think as a first target, it makes more sense of trying to target like a more acute population. And so that could be during exacerbation. I think that these inhibitor compounds have beneficial anti-inflammatory effects. And, especially if there's a viral induced exacerbation going on where you have, bacterial species, these compounds may be able to, reduce inflammation overall, but then also have antiviral effects as well as antibacterial effects. So I think acute settings, this would definitely be a target for that. In terms of eradication, we think that it could contribute, for folks who are on modulator therapies, but still maybe haven't eradicated some bacterial species. We're thinking about trying to look at if the microbiology could inform whether or not these might be useful sort of added targets for some sort of eradication therapy.
Okay, thanks. I guess one of the great things about drug repurposing is that it's been looked at in other patient populations already. You mentioned it's already been approved for use in some of the oncology trials. I think you specifically mentioned melanoma. Has there been any safety concerns raised to date?
There are some adverse events with these. I would say it's a little bit complicated, from the cancer studies, because they're typically always been used as sort of multi-regimen treatments. And so it's never just typically the one MEK inhibitor compound being provided under those settings. But there's not really anything that is striking, I would say. And I think, more informative, there's some groups taking these compounds now. Well, of course, they're in a clinical trial for SARS-CoV-2 infections. And so that will definitely inform whether or not there's adverse effects. And there's also some trials we're supposed to be enrolling before the pandemic started, that we're going to be looking at Staph aureus influenza co-infection. So I think results from those trials will be more informative on whether or not there's severe or adverse events or safety concerns that would be more relevant to the CF population. But so far, there's not really any, I would say, large concerns.
Great, thank you. I don't see any other questions coming up. If there is anything burning, it's your last chance to post something. But, really excited to see where this goes because, as I said earlier, we need more anti-inflammatories. So great work. Thank you.
Thank you.
So our last speaker will be Gail Stanley, and she'll be speaking about bacteriophages and its anti-inflammatory effects.
Hello, my name is Dr. Gail Stanley. I'm one of the pulmonary critical care fellows at Yale University, and I'm excited to present to you my work on bacteriophage therapy and decrease cystic fibrosis lung inflammation. I have no disclosures. I would like to first introduce to you what some are calling another looming pandemic, and that is one of antimicrobial resistance. It is estimated that by the year 2050, the number of deaths attributed to antimicrobial resistance will surpass the number of deaths per year attributed to cancer. This is because of the overuse and misuse of antibiotics, the ease of global spread of infections, and inadequate antibiotic pipeline. To tackle this problem, there has been a renewed interest in novel therapeutics, such as phage therapy. Phage was discovered in 1916 and was used for therapy with mixed success. And then there was the development of antibiotics, and research in phage therapy decreased for a long period of time. But now with the threat of multi-drug resistant infections, there is a renewed interest in the therapeutic use of phage. This is a nice figure summarizing phage therapy clinical trials in compassionate use cases of phage. And you can see that phage therapy has been used and considered for many different bacteria and for targeting many different organs and in many different routes of administration. As a reminder, bacteriophage are a virus that attack bacteria. There are two life cycles of bacteriophage. There's a lysogenic and a lytic. Phage therapy only uses lytic viruses, and these are ones that target the bacteria, insert their genome, hijack host resources to replicate themselves and package themselves back into virins until they overwhelm the cell, thereby lysing the cell or the bacteria and releasing the virins into the environment. Phage therapy is tested much similar to how antibiotics are tested against bacteria to see if they're going to be a viable therapeutic option. This is a lawn of bacteria on a petri dish, and you can see by clearance of an area of where phage was dropped onto the bacteria means that it is sensitive to the phage, whereas over here on the right, you don't have that clearance. And so this particular phage would not be a good therapeutic choice to target this bacteria. This is an example of what bacteriophage therapy can look like. And so this is a picture taken from a local newspaper of one of the first patients treated with bacteriophage therapy at Yale. And on the right-hand side, I know that the font is small, and I apologize for that. But this is the table 1 from a manuscript that I'm putting together, summarizing the case series experience of phage therapy in cystic fibrosis at Yale. So I want to highlight some of the clinical outcomes that we've observed. First and foremost, with phage therapy, there is a decrease in bacterial titers, represented here on the left-hand side, with a decrease in CFU after therapy. And then there is also a change in antibiotic sensitivity, a beneficial change in sensitivity after phage therapy. This graph on the right-hand side highlights different classes of antibiotics and how the MIC changes after phage therapy, and meaning that the antibiotics are now, or meaning that the bacteria are now sensitive again to the antibiotics. We monitor lung function through the therapy and have seen a significant increase in the lung function after therapy by measuring the predicted FEV1. And now I want to focus on some of the clinical beneficial bacterial trade-offs with phage therapy. So first, let me introduce to you what a bacteria evolutionary trade-off is. And this can be highlighted with an example from a phage, particularly the OMK01 phage. And in order for the bacterial will want to survive, in order to survive, bacterial will become resistant to whatever they are challenged with in their environment. So similar to how they become resistant over time to antibiotics with repeated exposures, if they're challenged by a particular phage, they have the likelihood to become resistant to that phage. And why this may at first seem to limit our ability to use phage as a therapy, I want to explain that you can choose your target wisely and force and manipulate the bacteria to have a clinically beneficial evolutionary resistance. And for example, this OMK01 phage targets an antibiotic pump on the surface of Pseudomonas. And in order for the Pseudomonas to become resistant to the phage, it must decrease this target. So it must decrease this antibiotic pump. And so by doing so, it will sacrifice the antibiotic resistance, and therefore it is a clinically beneficial way to manipulate the bacteria. We have used 3 different phages at Yale and have hypothesized what some of the benefits will be with therapy. As just discussed, OMK01 phage, which targets the antibiotic pump, and using this can force the evolutionary trade-off to resensitize the bacteria to antibiotics. We have also used TIVP-H6 phage, which targets the type 4 pilus on the cell surface of bacteria of Pseudomonas. And by doing so, we hypothesize that this will impair the twitching motility and decrease biofilm formation of Pseudomonas. And we have also observed a decrease in pyocyanin, which I will go over shortly. And then there is an LPS5 phage, which targets the lipopolysaccharide on the Pseudomonas. And by doing so, we theorize we can force an evolutionary trade-off by decreasing LPS, which would increase sensitivity to hydrophobic antibiotics, reduce extracellular elastase production, and impair iron uptake by the Pseudomonas. So I want to pause for a second and go over some of my methods for the analysis coming up. I collect sputum samples from patients before and then after phage therapy. The sputum samples are then cultured and Pseudomonas is isolated. And then 3 to 4 clinical isolates are randomly selected to further expand in culture. And these cultures are then measured for antibiotic titer to compare before and after treatment, and then are centrifuged down to create cell-free supernatants. And it's actually those supernatants of the isolates that I'm using to analyze the concentration of virulence factors from the Pseudomonas, and also this used to challenge the airway epithelial cells to investigate inflammation. So this was a finding after noticed after type 4 pilus H6 treatment, or the TIVP H6 treatment. The supernatants were noted to change from green to yellow. And this had us think about one of the important virulence factors in Pseudomonas, which is pyocyanin production, which is a potent inducer of epithelial inflammation, and is responsible for the blue-green color of Pseudomonas. And you can see that there is a decrease in the concentration of pyocyanin after treatment with phage. And I want to note that these numbers are corrected for the decrease in bacterial titers, or the decrease in CFU per milliliter after therapy. Then observing what kind of changes occur after LPS 5 treatment. And overall, when investigating the supernatants from all of the phages that we had in our repertoire, there was a significant decrease in LPS. But I wanted to ensure that, or I wanted to investigate the specific target of LPS phage. And you can see here in the middle panel that LPS significantly decreases after in the supernatants after exposure to the LPS phage, whereas after exposure to the type 4 pilus targeted phage, LPS does not significantly change in the cell-free supernatants, which is highlighted here on the right. Then shifting to airway epithelial inflammation. So remember, it is using these clinical isolates that were randomly chosen from the Pseudomonas cultures, and cell-free supernatants were used to challenge airway epithelial cells. And you can see a decrease in inflammatory signals, such as a decrease in EGFR here on the left after phage therapy, and then a decrease in cytokine production after TIVP therapy, with a decrease in IL-8 and a decrease in IL-6 here. So I hope that you find these observations and these investigations intriguing. And for the future of personalized phage therapy, I hope that my ongoing experiments will help inform the clinical application of personalized phage therapy. So for instance, if there is an MDR bacteria, then of course, one of the targets that would be useful is the antibiotic pump, and so definitely use OMK01 phage. However, if the bacteria develops resistance to that phage, or it is no longer multi-drug resistant, there are still benefits to phage therapy to target other bacterial virulence factors to reduce inflammation. And so we're very excited to continue this work with additional samples that are taken from the Sci-Fi trial, or the Cystic Fibrosis Bacteriophage clinical trial at Yale. We are actively enrolling and happy to take your referrals. We have funding for room and board and travel if geographically that's an issue for some of the individuals, and so happy to discuss that further with anybody. And I hope that my ongoing investigations will help inform the discussion on the use of single sequential phage versus cocktail therapy. And so by using a single sequential phage, we can smartly manipulate the bacteria in a way to be clinically beneficial to us, knowing that over time it's expected that they would become resistant to phage, but we can then sequentially retreat them to decrease other virulence factors, versus cocktail therapy, where the mutations in the bacteria are less predictable, and actually using multiple phages at one time may make the therapy less effective because there is a limited amount of resources inside the host bacteria in order to put together the virin particles, and limiting the ability for phage therapy to actually lyse or kill the host cell. So I'd like to thank you for your attention and highlight some of my mentors here at Yale, particularly my primary mentor, John Koff, and Dr. Paul Turner over in the Turner Lab, and then other important members at Yale, such as Dr. Kaminsky, our section leader, and Dr. Egan, the Yale CF program director. as well as Dr. Mathey, Dr. Haneden, our program director, Dr. D'Ambrosio, and Dr. Posick. And then everybody at the Yale CF program, Dr. Egan, Dr. Koff, of course, and then Dr. Brito, Dr. Talwalker, Jill Stewart, all of the clinical staff and patient volunteers. I'd like to thank everybody in my Koff lab and in the Turner lab for their ongoing support and assistance with all of these experiments. And this work was funded by the T32 training grant and now currently funded through the CF Foundation 3rd and 4th year fellowship. So I'd like to thank you once again, and I look forward to seeing you at the conference and for any questions.
Thanks so much, Gail, for a very fascinating, exciting talk. We're all excited about what phage therapy will bring us, and I don't think it's well understood that there are potentially anti-inflammatory effects as well. So that was great. So there's a bunch of questions here. Just one second. So can you just speak about, like, I guess, some of the challenges that may occur with respect to manufacturing these bacteriophages, storing them, and then, eventually administering them to patients? I know maybe done within a very, controlled environment as part of your study, but when it comes to, practical application.
Yeah, well, what is nice is that bacteriophage are environmentally sourced. And so there's a large collection and opportunity to gather phage from everywhere in our environment. So where you have high loads of bacteria, you have high amounts of phage because this is where they hang out and co-evolve together. Right now we have millions of phage on our hands. So just something to think about, that you are already living with phage on you. And we are just directing a certain phage for a bacteria that is causing the most problems for your lung disease. As far as the selection and then stability of phage, so phage can be on a table at room temperature for about 12 hours. We always recommend, if it's going to be longer than 6 to 8 hours, for the phage to be stored in a fridge. And so when we're administering these solutions to our patients, and they're nebulized, and we have studies with Dr. Murray at Yale, who has tested multiple different machines and nebulizer apparatuses, and they do survive. So we're able to see the phage after it's been nebulized. And it's sort of suspended in a little magnesium solution when we give it to our patients. And so it's very easy for them to administer their own treatments on an outpatient basis. Over time, developing a huge phage library is what the overall goal is. And with technology, at some point, we'll have such an array of phage in the future that we'll be able to take a sputum sample, culture up the bacteria, and have it input into a machine all of the targets around the bacteria as sort of like a screening on the outside, and then be able to have an output read of these are the 10 or 15 phages that are possibilities to use for this bacterium at this point in time.
How often do you think you would need to obtain a sputum sample to modify the regimen, and what are the impacts of various treatments like antibiotics?
Mm-hmm. Yeah. So you kind of get at the point of what's the optimal target population, and how are we going to design phage therapy in the long run? And so there's two things to think about. An acute patient, sort of like a bridge to transplant, very, very sick, very ill. Would you be more aggressive in their treatments? Would you do a sequential? Typically, phage therapy is for 7 days. And so would you follow every 7 days with a different phage, which we have done for some of our patients because they are so ill. And they benefit from having that acute intense treatment? Or do you have a patient, such are the ones that are being enrolled in our clinical trial, that are more stable and looking more at a longitudinal kind of phage design, that every few months we implement phage, and will this decrease the amount of antibiotics or the amount of exacerbations over their entire year?
Thanks. Question from Felix Ratchin: is the effect on Eflux pumps transient, or does it persist as phages tend to hang around?
So it persists as long as the target still exists in the bacteria. So eventually, as the bacteria die, that effect declines in the bacteria. The survivors are mutants that do not have the efflux pump anymore, and so will be sensitive to antibiotics, but again, will be resistant to the phage over time. Now, this has been happening. Bacteria and phages have been co-evolving for millions of years, and they will continue to do so. And so as over time, these mutants could change again, and they could regain the ability of becoming drug resistant. But then they also will have the target again for phage. And so you can kind of repeatedly treat them.
Okay, thanks. A question from JP Clancy. Has your EI&D experience determined whether host immune response to phage limits its effectiveness over time?
Yeah, that's a great question. And so that's the novelty of having a nebulized or sort of like a topical application in compassionate use cases versus doing an infusion of phage. Where you get less of a chance of an immune response. And so we haven't seen a meaningful increase in like IgA response or otherwise, that there have been some more complications with some of the infusions and the effectiveness of phage therapy.
Okay, thanks. Can you say about the selectiveness of phage therapy? Will it be nebulized? Does it survive nebulization? The impact of the oral flora? And the
and that's the work done with Dr. Murray down at Yale, and he's working on getting the results together for a manuscript. But yes, so we do test them, and always with our compassionate use cases in FDA, they have their independent testing as well to make sure that the phage are surviving the applications of it.
Thanks.
So yes, it is nebulized. It does survive the neb, and it gets into gets where it needs to be in the lung.
Thank you. What has your team learned about phage persistence in the airways as it might apply to dosing frequency or duration?
Mm-hmm. So as far as how long the phage hangs around in the airways, it persists, for better. We retest their sputums, and so we can measure how much phage is still in their sputum. And generally, it depends on how severe the disease is and of the patient to start with. But in general, it's around 7 days for how after the last treatment of the phage.
Thanks. What are some common public perception concerns that arise in recruiting and enrolling, and how can we as a community support response in our own educational processes with patients around these studies, as similarly being done in gene therapy right now?
Mm-hmm. Yes, I think there is some education with the general public about these viruses are already living inside of us and around us, and ensuring them that there's a very different life cycle of the type of viruses that we're using, or the phage that we're using in our therapy as far as lytic, and they can't insert their genomes. And so it's not a gene therapy. It's not going to change any of the human cells.
Thank you. What do you perceive as being the main barriers to phage therapy moving forward at present? What are the common side effects you've observed thus far?
Mm-hmm. So the common side effects that we've observed is a low-grade fever, or a little bit of irritation and increased sputum production around day 4 or 5 during treatment. So much similar to how our patients feel when they're getting antibiotics for an exacerbation. They have that little period where they feel like they're breaking up and all of the bacteria are kind of releasing their irritants in there. So it's a similar sensation. Never have we had anybody describe to us severe symptoms that they wanted to stop the therapy. So they've all been very mild symptoms over time. And I think just the challenge in developing and phage design is making sure that it's done in a rigorous manner. And so there's been a lot of research done in Eastern Europe, and it's hard to determine what the clinical trials were and were their standard controls. And so I think it's very important that when we study and do phage research, that we have those checks and balances and we have a safety design protocol. And one of my future hopes in my research is to develop a airway inflammation screening process for phages. When you're considering a new phage treatment, can I use that to challenge the airway epithelium to make sure that we are not doing harm? We would not want to induce inflammation by our phage treatment.
Thanks. And another question related to the use of phage for sinus disease. Have you considered that type of application?
Yes, we have, and there is absolutely a role for it. And so these are all the thoughts on the future uses of where it can be used. It's already been used for some compassionate case uses in the ear, and I'm sure it's been used in the sinuses, and we just don't have access to all of those outcomes. But you could think of using it in many different places beyond the CF world for chronic joint infections, chronic UTI, supraperiodic catheters. Is there a role for it in VAPs and acute pneumonias and stuff?
Thanks. I may have missed this. What is the timeline for your Sci-Fi trial now? Like, when are you expecting some, I guess, top line results?
Yeah, so we opened it up last spring for enrollment. And so the first, and we're doing the first outcomes in 6 months. So we're still waiting for that time period, but getting close to it. Mm-hmm.
Okay, thanks. I think we've addressed most of the questions. Anything else coming in? I don't see anything else. Okay, we do have, thanks so much, Gail, for that, obviously interesting talk, and we look forward to seeing how this develops. We have a few minutes to address any lingering questions from prior talks in the last 5 or 10 minutes here. I would like to start with, I guess, going back to Nicole. It's a fairly general question. Feel free to go with, any direction with this, but what do you see as being the main challenges, I guess, designing anti-inflammatory, anti-infectious studies now that there does appear to be some interest?
Yeah, I mean, I think we have to start with eligibility and the challenges in confirming those for the trial, and particularly around for our anti-infectives, establishing their micro qualifications for the study. Either based on microbial history that we are lacking due to this last year because of COVID, or the availability of sputum is really a challenge now for people who are on modulators. And I would say that the availability of sputum also pertains to early phase anti-inflammatory studies that need that sputum for inflammatory markers. So we need to step back and figure out, where the flexibility is with those eligibility criteria, so that we can continue with these studies, but still have, an applicable patient population. Then, of course, for the anti-inflammatories, we also have the challenge of outcome measures, particularly for the late phase studies, which are historically reliant on pulmonary exacerbations as an endpoint. And we know that those rates are really dropping. And so the feasibility of that endpoint is up question. And we just don't have the data yet to see, who are still having exacerbations and how we could enrich that trial population.
Thanks. Remaining question for, I think it was, sorry, I'm just looking for harm. Is from JP Clancy. Were there any microbiologic differences observed for the hypertonic saline groups?
Yeah, I wish it would have been possible to include that. It was already a challenging study, 3 to 6 years in Australia, Europe, and US. And collection of sputum would have been challenging also because of the age group. But I saw this interesting poster from Seattle on, what modifiers did on colony forming units in relation to disease severity, and definitely it would have been very relevant question to answer. So I think this is something for a follow-up study or for a registry analysis to address.
Thanks. Dave Nichols just asked a question on the use of CT versus MRI as a research outcome in children with CF.
Yeah, that's for me as well, I guess.
Yeah.
So for multi-center studies, CT, and we showed it now, is feasible. And there was also the Etalurin study that also included CTs, and it has been published in PLOS ONE. I think MRI is great, and actually we use it in our clinical routine. And I think it's a great tool in let's say phase 2 kind of studies, but for really phase 3 type of studies, it is a bridge too far, I think, currently because of the challenges of standardization and also accessibility throughout different centers, because there is a lot of competition, actually more competition on the MRI. It takes more time, especially in children. But in terms, we use in our clinic actually short-term follow-up of major structural changes that we want to see resolved. And so I always tell people, if you have the ability to start in lung MRI, do it, because it helps you really for individual management of individual patients. In terms of really standardization and multi-center studies, I think we need more time.
Thanks. I don't see any remaining questions, so I think we can wrap up this workshop. But I've learned a lot from all your talks, and I hope the audience has as well. And we really appreciate everyone's engagement with all the great questions, because I think it did enrich everyone's learning experience today. So we hope everyone enjoys the rest of the conference, and we'll see you next year. Thank you.
Thanks a lot. Bye.